we really want to talk about, this is not an industry bashing session at all, but a opportunity for us to discuss how we can really continue to share with each other and benefit from each other's work in a way that maybe in a little bit more formal or improved way. We're going to talk a bit about some projects that we've done. Public Health Seattle-King County and the Department of Health have been doing a project under the FHIC, the Public Health Fire Implementation Collaborative, and how we've been able to share knowledge and code and processes back and forth and post those processes into a GitHub repository so that other jurisdictions don't have to start from square one when they want to follow in footsteps. The code and everything they need to make that is someplace where they can leverage and use. I think MITRE being here in the room actually is appropriate because in many cases we've called on our non-biased, non-commercial partner to do an independent code review, make sure that none of our partners have accidentally put nefarious code into the mix. Keeping those assets clean and reusable. So I think we're going to go shoot through a really short didactic talk. Chris is going to run through the slides. Do you have the, here, let's give you the clicker. Oh, you can do it from there. It's a little glaring to stand here. And then we really want to get some discussion going with you all about what are the barriers to making this happen, and how can we make it easier for us all to collaborate? We had planned to do a demonstration of how to use GitHub repositories, but I'm not sure that it's really a space conducive to that. We may want to set up a webinar or something in the near future where you can walk through and watch Dr. Ravi demonstrate how he's uploaded our Rhapsody routes and uploaded some of our code into the repo. So let's see if we can get through this, and we need to finish promptly at 1:45 so that Dr. Shaw and the CDC Foundation can do their closing remarks. So let's get on it.
All right. For those of you who don't know me, I'm Chris Baumgartner. I'm the Deputy Chief Informatics Officer here at the Washington State Department of Health, and glad to be with you all here today. Wanted to talk a little bit about some of our public health fireworks, our fire projects, including our partnership with Public Health Seattle-King County on one of them. And then, as Bryant said, we'd really like to use some of the time at the end to think about how we can collaborate, not only on code, but also on things like the Public Health Workforce Data Learning Center, and what are some other things we could potentially share regionally. So our agenda, again, is we're going to review some of our fire projects that are actually in production, talk a little bit about our infrastructure project for fire, talk about two specific pilots we're working on right now. One you've heard about a little bit already. Ravi spoke about situational awareness, and then also our death data pilot with Public Health Seattle-King County, which Sargis will talk about. And then, again, we'd like to have a discussion at the end, and we may break up into some groups for that. So one of the things that we did before COVID even started, some of you may remember the opioid crisis that never went away and is still here and had a lot of challenges even during the pandemic. We worked with the Clinical Informatics Research Group at UW, and they developed a really cool application for us called COSRI, and it is a FHIR-based product that allows for healthcare professionals to be able to seamlessly receive prescription drug monitoring program data into their electronic health record system. And what made this project even more exciting to me is it not only allowed them to get the data, it actually applied CDC guidelines as well as Washington State opioid prescribing regulations in a clinical decision support mechanism to help them understand how they should probably respond or react to that information. Rather than trying to consume all those individual records, they could have some guidance on, hey, based on this, guess what? Your patient is receiving opioids and benzodiazepines, for example. That's a risk, and this is why it's a risk, and these are some things you should consider as part of their treatment. And so this is, again, fictitious data. For those of you who love Marvel like me, you'll notice our patient is Norman Osborn. He had some serious complications when he became Green Goblin and needed some medications, but he's being treated here. And this gives you an idea of the Washington State consulted threshold that you'll see there. It also gives them the CDC thresholds and advisories, and again, gives them some patient risk assessments over here through clinical decision support. And this just shows you, again, some more of that information from the clinical opioid summary from COSRI. So again, kind of a novel way to partner with academic partners and develop something that actually benefits our healthcare providers who are trying to leverage data that we had at the Department of Health. Another one, I'll skip through this very quickly because we've already heard a lot about it, but again, our next kind of big project that is in production was WA-Verify. As Bryant shared earlier, there's a lot of the FHIR bundles, again, are the basis behind that, and it has been very well received and accepted. It's very simple to use. Going to our website and entering some basic demographic and contact information, you're able to get back your QR code within, less than 10 minutes usually?
90 seconds.
90 seconds. And I will say, even for me, it worked. I live in Idaho, but my provider's in Washington, and I was able to get my records over there, and they were entered, and they showed up. It was amazing. So again, we also talked a little bit about some of our plans for moving forward with international patient summary and expanding WA-Verify. This includes even some more novel ideas around looking at things like mental health advanced directives or physical advanced directives that might be considered. And I think where that plays in, again, to reusing something from COVID to benefit something else is all states are trying to respond to needs around 988. And standing up the Behavioral Health Crisis Center line. And so it's another way we could re-leverage, something we've already built to meet another need. Another great example along those lines is our ability to use the WA Health application as well for situational awareness. Guess what? Under 988, we need a bed registry. Well, wouldn't it be nice if our healthcare providers had one system to report to that met multiple needs instead of having to report to separate systems the same information? So those are some of the things that you could be thinking about as well that I know we've been thinking about. To move FHIR forward more broadly at our agency, we have recognized that there is a lot we can do with our Rhapsody integration engine, but there are also some other components that we need to consider to have a more viable FHIR structure moving forward. For that, again, we've been partnering with the University of Washington, and they're helping us evaluate some of the products that are out there on the market. You've probably heard of some of them. There's FHIR-ly, there's AidBox, Smile CDR. And so we're very interested to kind of see, what's out there, what are the tools that we need that we don't already have, how can we leverage tools we already have in place, like Rhapsody, to meet some of the needs we have as far as a FHIR infrastructure. And so that's a project that we have going on right now. Again, from that, we're also trying to figure out two actual real-world use cases for that FHIR infrastructure. Again, Ravi talked quite a bit about situational awareness. There's a great IG out there being worked on from FHIR standpoint, along with the Helios FHIR Accelerator for Public Health. There's 3 major projects there. One is situational awareness, one is bulk exchange of immunization data, and the other one is an attempt to look at ways we can exchange data better between healthcare and public health. For example, querying healthcare when there are missing information based on a lab result, for example, and you can talk to Michelle Barber more about that one. She helps lead that use case. Ravi helps lead the Saner use case, and Mary Beth, I think, if she's still here, helps with the immunization use case, of course. So it's kind of cool. We actually have representation from all 3 of those here today. But again, the FHIR protocol would really help automate this, streamline it. And again, think broadly. We're hoping to maybe leverage this as well, again, for some of our 988 needs around bed registry. And the use of smart FHIR apps, could help, for example, with those smaller behavioral health facilities that would need to report bed availability to the bed registry, but might not have robust EHR capabilities. So I think there's a lot of neat potential there for that. The next one I'll just jump into briefly for a little bit and then turn it over to my colleague here. But under Tier 3 DMI funding from CDC, we have a FHIR project in grant, which requires us to report data to CDC, death data specifically to NCHS. And we had the amazing opportunity through the Public Health FHIR Implementation Collaborative to work on a pilot, though, of how else could we leverage that same VR-DR implementation guide for FHIR to also share data with our local partners. And so we were able to partner with Public Health Seattle-King County to send them death data. We also hope to look at possibly a phase 2 around that as well. But it's a really exciting opportunity to think about how FHIR can be used not only between us and healthcare, but us in between other public health partners. And with that, I believe I will turn it over.
Hi, everyone. My name is Sargis Pogosjans. I'm representing Public Health Seattle-King County. Full disclosure, this team that was participating at this pilot is outside of my direct oversight, but I had an opportunity to chat with them about this, and we have very similar.
More evidence that some local health jurisdictions are resourced better than the state.
I wouldn't say
lots
better,
of
just
teams.
different. But to kind of set the stage of King County, specifically the medical examiner's office, like a lot of our programs within Public Health Seattle-King County, we have parallel processes with the state. So we have our own surveillance systems, we have our own systems. The MEO is no exception in that regard, where they have their own data system and infrastructure. And they receive information, and sorry, I'm looking at the laptop because looking this way is hurting my neck. But they receive information from all of our emergency medical providers, our hospitals. They respond to a lot of unfortunate events that happen in the county. But the focus of this was the data transfer from the state system into the local system. And previously, this was done through download and then upload. So downloading from the state system, uploading it into the local system. And we repeat this process for many other systems that we have within King County. So this is why this pilot was a first kind of opportunity for us to test this out, understand what are the resources needed for it, and then hopefully apply what we learned to other, some of our other programs. And, okay. So the goal for this was to understand what do we need, what are the steps to go through this, what are the framework, and then understand how do we sell this to our own department. What kind of resources do we need financially and people resources, staffing resources, IT resources. And then there was a need from our medical examiner's office as well because the current system was changing, so they had to reconnect it as well. One of the major barriers to this was the team that's using this system is our medical examiner's office, and they respond to events in real time. So there is no possibility of any lag or any sort of system being down. Just for context, pre-COVID, there was about 2,500 deaths that they took under jurisdiction, and that includes any sort of investigation that they're doing on an individual who passed away in King County that they end up taking jurisdiction. Post-COVID, it's been about double every year. So the volume that they're seeing has also increased. So they're working under a lot more stressors, and there's also funding pressures, and the majority, if not nearly all of the staff is dedicated to response, not so much infrastructure. So the largest, one of the larger barriers was how are we getting funds, which fortunately this pilot was able to resolve. And then it's, what is this? Why is this useful? And how is this gonna help? And a major component to that barrier was the data right now gets downloaded and uploaded, and no one really notices from the investigation side. So most of our medical examiners, pathologists don't really notice that change. So switching to a FHIR setup is not gonna make their lives any easier. So it's trying to understand like why are we doing this pilot and who benefits it is a barrier. As I mentioned, I'll go through these really quickly, but the main task was how is our internal system set up, and how does the data transfer look like, and where does each data set go to? So a major component of this is just the mapping and testing out to make sure that everything's coming in. Again, because this is real time, mistakes are required to be very limited and fixed very quickly. It's a 24-hour business, so there's also a lot of very few opportunities for people to make any sort of adjustments and outside of normal business hours. So the way that this was primarily set up was through an external person that was hired as an intern or over the course of several months to do all of this mapping and testing out the dummy data sets to make sure that the transfers were going through, and working with DOH on getting all of the elements that were making sure that they were being transferred to the new platform and then being inputted into the medical examiner's data system correctly. So far, the data exchange has been great. There has been a lot of lessons learned in terms of how many hours it takes and what kind of staffing is required. But primarily, the biggest educational tool was understanding how to advertise internally, and then also seeking out the fact that we need specific finances in terms of the build out and working with the vendors. The key component was also that no specific agency is alone in doing this, where we had to work not only within our medical teams, DOH, and then different vendors that were building out the systems, both at the DOH side and then the King County side. The project is hopefully going to go live soon, and we'll switch over from Raspberry to the FHIR connections. I'm not sure what the timeline is. Other people could figure that out. But the biggest component that we're hoping to use this pilot for is a bidirectional transfer. So again, because we have our own systems, where this only really applies to data coming into our system, but then for data coming out of our system back to the state system is manual entry. And when we were talking to our leadership, they don't really understand the selling point of the new download import, but they very much see the cost benefit to no longer having all of their staff who are busy responding to increasingly more events with less funding, not having to double enter the same information into two systems. So the goal is to be able to work on a second round of this where we can eliminate that and create a bidirectional tool. And now that at least one part is using the same thing, the mapping is more complete, and then we'll be able to hopefully have a less of a hurdle and less of a hill to climb to create that bidirectional partnership. But it also requires support from DOH and working a lot with DOH on getting that set up. I think that's the primary goals of that one. And then we have been thinking about how do we apply this to all of our other systems. And because King County and DOH have a very similar relationship across all of our partners and segments, a lot of it does have to deal with no longer having to do separate different kinds of imports, exports, where we have very similar systems, but they're not connected, and a lot of it does require a manual export, import. But yeah, I think that's my segment.
Yeah, so just a quick acknowledgement slide, especially given that we're highlighting partnerships here. Again, we had amazing partners, not only within state and local government, but with our academic partners and private partners and quasi-government partners as well. So a big shout out just to these individuals and some of these amazing partners that we had for this. With that, with the time we have left, we really, again, we're hoping to have just a discussion. I don't know, Bryant, if you would still like to try to break up into some smaller groups or how you would like to look at this.
Yeah,
But
so that my thought is we've got enough jurisdictions in the room to give everybody more of a chance to talk. The three of us would, and Ravi's going to join us as well, break up and maybe have 3 or 4 clusters of people get together and talk about, processes, potential barriers, or how we can share these assets. It took COVID for I don't know, I can't speak for everybody, but I took COVID for our agency to recognize that we had to start using publicly accessible GitHub repos that we could share in and out. Previously, we had been using code repositories before, but they're always behind gigantic major firewalls, not allowing us to really benefit from those multi-partner collaborations. They were just code repositories amongst our internal developers, as opposed to the real power of sharing is working these routes out, working these capacities, and then sharing them so other people don't have to start from scratch. And I'd love for us to, get those discussions going and see if there are barriers, if we can start working on them. And oftentimes they're policy barriers, not technical barriers. But what's
if I may, Brian,
yeah.
if anyone's interested in specifically collaborating on workforce development platforms, if you could join Janet and I, we'll meet here in this front corner, and then maybe we can have a group focused more, or 2 other groups more focused on specifically code sharing.
Yeah, let's have one on like Rhapsody route code sharing in the back corner, and maybe one on FHIR processes and capacities up here in the middle somewhere. Does that sound like a
Yeah,
place
let's
to
do it.
start? Okay.